going in Lee's office.
Oh, okay.
My wife's looking at what the boss would be.
Hi, how are you? Have a seat. Just hard for getting this ready here, but you guys want some coffee?
No, I'll do it.
No, thanks. Okay.
Got you by surprise, didn't I? Got me by surprise.
Yeah.
Well, only in the sense that I didn't expect the grading to be quite as high as it is.
Yeah.
And I will tell you about that in just a second. Okay, your PSA was just a little bit elevated. It wasn't elevated tremendously. Yeah, I think last year it was what, 4.2?
Yeah, earlier this year.
And then it went to 4.8, then
Yeah,
5.4.
Yeah.
In feeling your prostate, however, your prostate does not feel to be an abnormal, a normal prostate. A prostate should feel like a nose, and it should be smooth one side versus the other. And when it's not, it really doesn't make a difference to me what the PSA is. Something's not right, and I've got to try and figure that out. So we do this prostate biopsy on you, and before we did the biopsy, we knew that the right side of the prostate, toward the base of the prostate, was a firmer area. Okay, not like a smooth. It was one part was a little bit firmer. So we do the biopsy, and that biopsy is showing us a Gleason 9. And when we measure prostate cancer, we go on a scale of 2 to 10. 2, 3, 4 is the little kitten. 5, 6, 7, pussycat. 8, 9, 10 is the lion in the jungle. So you have an aggressive type of cancer based on the 4 cores of biopsy. There was 1 core that was 9. There were 3 cores that were 8. Your clinical stage, and when I say clinical stage, that's how we feel the prostate, is a T2A. Okay? So now we have a high-grade tumor that I believe is confined to the prostate, but we have to make sure of that. And there are 2 tests that I want to send out for you in terms of seeing if there's any involvement with lymph nodes and seeing if there's any involvement with the bones. One is called a bone scan. The other is called a CT scan. We'll be taking some blood on you today, so I can get those tests done.
They're both blood tests.
The blood one is a blood test today. What kind of work do you do?
I'm retired.
Okay. Children?
1 boy.
1 boy. There is also something. Well, let me back up a bit. I'm going to tell you about what options are for you, but you are not by any way, shape, or form making any decisions about options. And the reason that I say that, because I can't make decisions about options or guide you in the right way until I get a couple of tests back. Okay? The reason I say that, if God forbid there's something on a bone scan or something on a CAT scan, then we're going to go down a different course of treatment. If it's all confined to the prostate, then we have options to potentially cure you. Okay, so it makes a big difference for us with what we do here. The other thing that I would like to do for you and to you is I want to do some swabbing of your cheeks. There's a genetic test that we do now. So not only will it help us determine your prostate cancer and long-term aggressivity, but may also help you with your son. There's certain types of prostate cancers that are genetic. So we'd like to try, and this is brandy spanking new. We've only been doing these over the last half a year or so. So it's that new. Now, if it were to come out unusual, I will tell you that you'll be getting a phone call from a geneticist. You'll set up a phone call so they can explain to you what the abnormal genes are, because there are so many genes, and as the urologist, I couldn't begin to tell you where we go with this. Okay. Now we've given you one thing. Now I'm going to say to you, not the cart in front of the horse, but there are different options for you for treatment. If there were disease that were outside the confines of the prostate, the types of treatments that we have today may either be giving you hormonal shots, may be giving you immunotherapy, there's even chemotherapy that is a potential. But those, we don't, I've got to make some decisions if God forbid it comes back like that. And I'm not expecting it to. Your prostate is not a big prostate by measurement. Your prostate came out to be about, where is it? 12 grams, which is not a big prostate. The other way of treating prostate cancer is to either give you radiation therapy to your prostate. And there are a couple of ways of giving you that type of treatment, and if one of the decision points down the road was radiation therapy, depending on the type of treatment, we'll have you meet with a radiation oncologist so you can sit down and discuss what the potential treatments may be. Surgery, though, is yet another type of treatment for you, where using a robot, I would be sitting in a booth operating on you to take out your prostate. That procedure that operation, I do over at Hackensack. And I have two other urologists that I work with that we work together as a team to do this. There's a Dr. Lavallo and there's a Dr. Ahmed. If we did it to you this afternoon, you'd be home tomorrow morning. It's a lot different than when we used to make incisions into the body to do that. There's something called nomograms, studies that, based on some very preliminary information, I put into the computer, and it tells me a lot about your type of cancer so far. And what I've already done, the probability of your surviving at 10 years after treatment and 15 years after treatment, 99%. That's not a bad, okay. That, however, there's also something that we call progression-free survivorship, And that means that, yes, you may be alive, but the disease may have progressed, and may need to do other treatments for you. And those numbers are not as great as the 99%. They come down to 47% at 5 years and 32% at 10 years. So what that tells me for you is that you will most likely need some other kind of treatment somewhere down the line. And that's how some of this genetic testing is going to help us as well. When we look at, and again, these are all statistics, and when we look at the statistics, and we see that based on the pattern of the cancer, and I said we judge it on a scale of that 2 to 10. Your cancer turns out to be the 9, and with a 9, if I were to take out your prostate, I would probably find lymph nodes in samplings that I would take in about 19% of men that I would operate very similarly to you. The chances of this being outside the capsule or the lining of the prostate that we can't feel but microscopically may be there, is about 70%, so that's up there. That's high. Meaning on the converse that having it confined completely to the prostate is 30%. If it were microscopically outside the confines of the prostate, well, what do we do for you? We give you radiation therapy to the area that we took out the prostate.
You would take out the whole prostate?
The prostate comes out, the glands behind the prostate, something called the seminal vesicles, come out as well. This affects you sexually in the sense that while you may have the sensation of ejaculation, if I'm taking out the prostate and the glands behind it, you're not going to have any fluids coming out anymore, because the prostate and the glands make about 99% of the fluids. You're not going to have fluid coming out. If we took out your prostate, about 50% of men are not going to be able to have erections by themselves without the aid of potentially a medication, a Viagra, a Cialis, a Levitra, something to help you move along with your sexual activity. What else can I tell you?
What about urine?
Urination, in terms of urinary leakage, after removing a prostate, men do very well with control of urine afterwards. 1% of gentlemen will have no control. So if you're that one guy out of 100, that's a problem. Let's keep knocking if that's not going to happen to you. 30% of men, however, will have incontinence. Did I just say 1%? Now I'm saying 30%. There's a difference here. If I told you after this procedure, or after the surgery, to go pick up a 50-pound bag of sand, and you went to lift that up, and you had a drop or two come out of the tip of the penis and wet your shorts, to the purist, that's urinary incontinence. Okay, is that going to make a difference for you in anything that you do and affect your life in any way? Not at all. If you were in a gym and you were doing jumping jacks or what have you, women have something called stress incontinence, which is very, very common, where you may leak where they may leak a drop or two of urine. shouldn't be a major problem here. There are 2 websites that I would like you to go to. One is Mayo Clinic.
Okay.
That's where I trained. I think they have a very good, non-biased, you can get a fair assessment from their website about prostate cancer. The other place that I send patients to look at, Johns Hopkins. Now, depending on who will know about your prostate cancer, you will hear everything about treatment options at a lot of different ways of treating prostate cancer. And everybody knows the best on how to treat prostate cancer. All your friends and relatives are going to have somebody that they know that had a prostate cancer that was treated this way, that way, the other way. There's only one thing that they don't know. Not all prostate cancers are the same. They don't know what your grading is like. They don't know what your prostate feels like. So what we're trying to do here is eventually come up with a treatment that's individualized for you. You may have heard on ABC radio, there's a Dr. Lederman.
Yes, I know.
Yes.
In New York. I mentioned that to you to say, stay away. He is not somebody to be dealt with. He has a lot of claims. I don't think that all those claims are quite valuable and honest. He has a Curtis Sliwa
Yeah.
from the Red
Yeah.
who tells you, if I would have known with my stage 4 prostate cancer, I would have, and I have the difficulties, I would have never been operated on. Number 1, Curtis, I know the guy that operated on you. Number 2, nobody operates on stage 4 prostate cancer. It doesn't happen. So, everything that he's talking about, stay away from Gil Lederman.
Yeah.
That's my opinion. If you want to go see him, you can go see him, but I don't know how many urologists that would say to you, yeah, go see this guy.
What do you think of Sloan Kettering?
I think very highly of Sloan Kettering. I don't think Sloan does anything special at this point in time for localized prostate cancer. If you move the cart a little bit, there's a doctor that we have at Hackensack, a Dr. Robert Alter, who is a uro-oncologist that we use all the time, who basically does the same kind of treatments if we need to, and puts you on the same studies if we need to, as I have at Memorial Sloan. Okay. So what we are going to do now, I want to get some blood from you. We want to line up the bone scan. I want to line up the CAT scan, and then I just want to swab your cheek.
Okay.
Right.
I just have a question. As far as like if it is found outside the prostate, that still doesn't mean that he can't just do radiation.
Oh no! If it's outside the prostate, he can do radiation. But if it's outside the prostate, radiation plus hormonal therapy together.
Okay.
Okay, for 2 years. For 2 years, you would have hormones, and what that means is every 4 months, I will be feeling the prostate, and I'll be getting blood tests on you, and I'll be giving you an injection.
And what does that do? It slows the progression down?
Essentially, if we're giving radiation therapy, the purpose of the radiation therapy is to kill the prostate cancer. The purpose of the hormones truly are to starve any cells that may be left, that may be around.
And is that, I have done some reading, that would be Lupron?
Lupron,
Lupron, that's what I meant.
L-U-P-R-O-N, yes. And there are a number of other newer medications that we may add to that if we have to, but I don't think we're at that point yet.
Okay. Okay.
Write down your questions. I will answer whatever we need to answer, and if I don't have an answer, we'll make sure we get the answer for you. Okay? I haven't been doing this for a long time, only 35 years. So, I think there's just a little bit of experience.
That's your phone. You should have turned that off. You should have turned your phone off, Art.
No, that's not his phone.
Oh, that's not his?
So I'm getting yelled at right away.
That's because his is like that too.
That's you. What? Oh. It's my wife showing me a picture of my granddaughter.
Oh.
Thank you very, very much.
So I just want to make sure I have it right. It was found on the right side, so it was only found on one side,
One
not
side.
both.
Mhm.
Okay.
One side in the here. Let me give you stuff here. I'm gonna draw a picture for you so you have this. Left, right. Four plus 5, 4 plus 4, 4, 4 plus 4. B9, B9, B9. So if we're looking at this diagram, this is the area up here that's positive. There's a 4 plus 5, a 4 plus 4. So you add two numbers together, that will give you the, and when I say benign, no cancer. Okay. Any other questions?
Nothing I can think of right now.
I hit you up with a lot today, I think, and you're gonna be finding a lot more. Please write it down. Okay. Don't go driving yourself crazy. You've got something that is potentially curable. Okay? This isn't, there are certain types of cancers that are out there that we deal with that it's, we have to send you to the oncologist right off the bat. This is not that type of thing. You may say, dude, why don't we start by giving you chemotherapy or by giving you immunotherapy? The studies so far, and we're in a very exciting aspect of prostate cancer with all the new types of treatments that are coming out, but we're not to a point yet where we would say, if I use a bladder cancer as an example, before I would ever take a bladder out. Years ago, bladders would just come out and we'd treat you afterwards with other medications. Now we don't do that. Now we get you on the medications first, right off the bat, because we have found out through the studies that success rates and longevity and what have you is much higher when we do that. There's some studies going on, but we don't have the information there yet.
Okay.
Okay, so you don't think it's spread at all though, huh?
Art, that's what I wanna find. And the best that we can possibly tell, that's what I wanna find out with you. Your medical doctor is who?
Dr. Al-Khalili.
And where is he?
Farallon.
Huh?
Farallon.
You guys are living in
Farallon.
the bone scan and the CAT scan. We can get down the hall at the radiology group here, or I can send you to the one in Walblick, which is the Radiology Associates at Valley. It's 6 of one, half a dozen of the other for the preliminary testing. But as I told you, if I were to operate on you, I'd be doing this at Hackensack. I used to do these at Valley because, unfortunately, we do too many of these at Hackensack. They don't do enough at Valley to truly experience and doing numbers is what we need to do.
Mm-hmm.
When will I get the results of the test? How long does it take?
Yeah, usually about 3 or 4 days afterwards. Okay, just wait here for a second.
Did you see the picture with the dogs?
No.
Melissa? Second, all right, so if you wanna print up a label, thank you. Okay, my friend, just open up your mouth for a second. I get to play dentist as well. Okay. And then what I need here, I'll give you this, and and what I need is a BMP.
I'll be
And then he's gonna go see Gloria
Gloria, right.
for a bone scan,
Okay.
CAT scan.
I'll take care
Okay?
of it.
Why don't you just go with Melissa? Good. Like I said, just put it down and whatever it is, try and get back to you as soon as I can. But we're gonna see you back after the bone scan and CAT scan anyway.
Okay,
Okay?
all right, thank you.
Alrighty, Shirley.
Sure.